12 out of 100. That's how many lives are likely to be saved when the steroid dexamethasone is given to COVID patients on ventilators. 60 are likely to recover anyway, and 28 will die even with the drug. These statistics are from the world's largest clinical trial for COVID treatments, based in the UK. It's one of many trying to figure out which drugs work and which ones don't. It might seem simple, but oxygen is the main therapy. Oxygen saturation in the blood usually sits around 96%. If that starts to get below 93%, more is given through nasal prongs. And the steroid dexamethasone is given to patients who need oxygen.
When your body has an immune response to an infection, like COVID, it causes inflammation. We use the dexamethasone to reduce that inflammation so people can breathe easier.
The drug only benefits patients who need respiratory support. There's no evidence it's helpful before patients get to that stage. Dexamethasone is one of the 3 drugs being used to treat COVID patients in Australia, alongside remdesivir and tocilizumab. First developed for Ebola, the antiviral remdesivir stops coronavirus from replicating, so it's more likely to be useful early on.
It seems to be of much less benefit once someone's on a ventilator because you're through that viral replication phase, and by that time, an antiviral drug isn't going to be as effective.
In a trial including more than 1,000 patients, the drug reduced the recovery time of people hospitalised with COVID-19 from 15 days to 11.
So there's no single drug that's most effective. What we found is we need to use a cocktail of drugs depending on the symptoms that the person's having and how far advanced their COVID infection is.
Tocilizumab is another anti-inflammatory drug. In a number of large randomised clinical trials, it's been shown to reduce the chance of dying by 15%. It's used for patients who already need oxygen. But there's one set of therapies we don't have in Australia yet. They're called monoclonal antibodies, and we don't have any that specifically target this virus. It's a man-made version of the antibodies that we naturally make to fight invaders. These drugs seem to work better in a pre-hospital setting.
If we give it at that really early stage, that reduces the risk of hospitalisation by about 70 to 80%.
And research shows they can also be helpful in hospital if a patient hasn't started to produce their own antibodies.
If you measure whether someone started to produce their own antibodies, if they haven't, then these monoclonal antibodies seem to be able to reduce the risk of dying as well.
And then there are treatments that don't work.
A lot of good things have come out about the hydroxy. A lot of good things have come out.
The anti-malarial drug that was hyped early on in the pandemic has been proven to have no efficacy against COVID-19. The results of 6 trials show the drug doesn't reduce the chance of dying and doesn't shorten the time patients spend in hospital. In fact, it even exposed patients to potential side effects, including heart damage.
The reality is that we've talked about lots of different repurposed drugs. The majority of them haven't worked.
The common anti-parasitic ivormectin also seemed promising. Clinical trials are yet to demonstrate that it's effective against COVID-19. One study found that at high concentrations, it can stop the growth of the virus in a petri dish. Unfortunately, many lab results don't work inside the human body. For the drugs that do work against COVID-19, their effectiveness very much depends on the right timing.
Dexamethasone may actually be harmful for someone who's not requiring oxygen. So if you gave that to every person in Australia who gets COVID, it might actually do harm.
It's all about giving the right drug to the right patient at the right time. Because so far there's no silver bullet for COVID-19, though prevention is always better than a cure. So what's likely to work is a vaccine.